his side. It's kind of a one-man conference which he was organizing, and we all learned quite a few things, and we are sure going to miss this series. And I really hope that you would be starting something like this on a similar platform or some different ideas again, because we would be really waiting for it. Okay, so let's start with today's topic. It's going to be basically about hyperparathyroidism. Now, there are two things which we need to understand. One, till now, maybe till a few years back, this was almost out of the gambit of ENT surgeons, and there were very few places where it was being done. In fact, I did not see even a single case during my post graduation. And it's only for the last 5 years or so that now we are doing quite a few parathyroid surgeries as well. And it's basically the reason, is the second reason why this is common now, is because it's a good teamwork which is really required, right? So when I mean teamwork, if you see the three names right on the left hand side of the screen, these are the names without whom this whole, any of the slides actually in this presentation would not have been possible. So Dr. Sandeep Mathur and Dr. Balram Sharma are from the endocrinology department of our institute, and Dr. Karun Sethi is the nuclear medicine specialist. And there are a lot of other people involved in the team, but the main diagnostic thing, which was really not considered in many patients, is what makes this team successful, and that's with the endocrinologist and the nuclear medicine people. Right, so the teamwork, which is very important. Now we all know this is what Earth was, and it's something like this right now, and it's just because of a very small particle which we call as the coronavirus, right? So very small thing has really changed the face of the Earth as we knew it maybe till 2 years ago. It's more relevant in today's talk because parathyroid is something similar, right? And it's kind of, it's very small thing, like an ant does to the elephant when it gets into its trunk. Similarly, a parathyroid, a very small, we all know it's a few milligrams, very small gland, right? Four glands. And if it gets problematic, like just the COVID virus, which affects the whole earth, the small parathyroid disease will affect the whole body. And this could lead to multiple problems, which we are going to discuss. Now, just few short animation videos to talk about the anatomy and the physiology part. We all know there are four parathyroid glands located on the posterior lateral part of posterior aspect of the thyroid gland. Now, these are very, very small glands, a few milligrams. Now, these glands, the chief cells which are present, they have the cells which release parathormone. But the regulation of this parathormone release is by blood calcium levels. And when the calcium levels increase, they come and attach to the transmembrane part of this release, and then it stops releasing any further parathormones. Now, parathormone basically, one, it acts on the bones and takes out calcium from them and brings it into the blood, therefore increases the blood calcium level. It also absorbs calcium from the renal part and therefore increases blood calcium levels again. And third action is on the various intestines, right? And that is where again, with the help of vitamin D, it absorbs calcium. So it increases the blood calcium levels. We all know that by acting on bones, acting on kidneys, and acting on the intestines. Now this is the normal physiology, right? What happens if it becomes pathological? So if one of the glands, right, even if one, it increases in size and becomes autonomous, kind of what happens in a parathyroid adenoma, this could involve more than one gland, then it increases lot of parathormone in the blood. Now, the release of this parathormone, we all know the various sites where it's basically acting, right? Now, if it increases a lot, then it leads to a lot of implications. The first most important one is on the bones, right? It chelates out a lot of calcium into the blood. It's kind of an osteoporotic activity. The bones become very weak and tend to pathological fractures, bone pains, which happen. It again acts on the kidneys, which we all know, right? There's a lot of calcium in the urinary calcium area, right? Urinary calcium increases, so renal stones. It acts on the brain where you have a lot of fatigue, memory loss, etc. And in severe cases, depression and anxiety. Various arterioles or arteries, there's a lot of atherosclerotic plaques. It can even lead to neuromuscular disturbances in the form of various arrhythmias, and it acts again on the stomach, where it leads to a lot of acidic reflux. Again, on the intestine, it affects the gut mobility also. Now, it's considered that an untreated parathyroid disease decreases the life expectancy by almost 5 years. It also increases the chances of various cancers in the body, the main ones being that of colon, renal, breast, and prostate. Right. So this is all a pathological parathyroid can lead to. So that would be affecting the bones, affecting the kidneys. Right. It causes renal stones. We all know about that. The abdominal groans, renal stones, psychic bones, yeah, and pain in the bones. Right. So that's what happens. You have all those issues which come up, and these are the multiple issues which a patient of parathyroid disease can face. Now let's look at what we mean by hyperparathyroidism. Now, primary hyperparathyroidism is something like this. Now, this is a normal calcium metabolism which we see, right? If there is a decrease in calcium levels, it will act on the parathormone, releasing the parathormone. Then there is an increase in the absorption of calcium, increase in renal absorption, and increase on chelation of calcium into the blood, thereby leading to increase in calcium levels and normalizing it. Now, in case of primary hyperparathyroidism, we just see that one of the parathyroid glands, or maybe sometimes multiple, usually one, has an autonomous parathyroid adenoma. What this leads to is an increase in the, what this leads is an increase in the parathormone levels, therefore increase in calcium absorption from the gut, increase in reabsorption from kidneys, and blood chelation from the bone chelation, therefore increase in the calcium levels. So primary hyperparathyroidism, we have increased calcium, we have increased parathormone. The treatment would be surgical removal of this adenoma. It's very obvious, right? Importantly, we need to differentiate from secondary hyperparathyroidism. What happens in secondary hyperparathyroidism is there's a particular disease like vitamin D deficiency or renal insufficiencies, which actually lead to decrease in calcium absorption levels, decrease in renal absorption, right? And the blood bones with the calcium which goes from the bones into the blood is also decreased. Primarily the first two, because there's vitamin D deficiency, absorption doesn't happen. If there is renal failure, again reabsorption does not happen. So we in fact have a decreased calcium level. This leads to stimulation of the parathyroid glands, and what we have is a parathyroid hyperplasia kind of a picture, right? Now this parathyroid hyperplasia leads to increase in parathormone. Leads to increase in parathormone, which then you have various activities of absorption, again absorption of reabsorption from the kidneys. However, the blood calcium level does not rise very high, so it will be either low normal or normal in case of secondary hyperparathyroidism. So though the parathormone levels are increased, the calcium levels however are not very much increased. The diagnosis would be based on checking vitamin D levels and looking for any renal insufficiencies, which obviously will then need to be treated. Now, tertiary hyperparathyroidism is again the same reasons, but the hyperplasia which is now happening becomes autonomous. Right? Even if you treat the secondary causes, that is vitamin D deficiency or renal failures, it will not really now cure the tertiary hyperparathyroidism, because now the hyperplasia has become autonomous. Right? It's not going to improve. So parathormone increases, the calcium level therefore further increases. So primary and tertiary hyperparathyroidism, we will have an increase in blood calcium levels. Primary would usually mean an adenoma. It can be hyperplasia sometimes in primarily. Usually in tertiary, it's always a parathyroid hyperplasia, right? This is what we need to remember, and that is where the diagnosis is important, and the role of endocrinologist is very important, very important. Now, what could be the reasons for primary hyperparathyroidism? It could be simply idiopathic. It could be familial. That's about the parathyroid adenomas, right? Now, parathyroid adenomas, familial are MEN1, MEN2A, which is actually now called as MEN2 syndrome. And I actually came across this term of MEN4 syndrome also. That is, till 1 year back, I didn't know MEN4 existed. MEN4 is actually, tumors of parathyroid and anterior pituitary with adrenal tumors, reproductive organ tumors, right? So that's MEN4 syndrome. So in fact, men 1, men 2, which was called as 2A, 2B is now called as men 3, right? So in the latest literature, that becomes men 3. So men 1, men 2, and men 4, and then familial isolated hyperparathyroidism. These are familial causes for parathyroid adenomas. What all investigations do we need? Obviously, we need total calcium levels to see if the calcium levels are really high. We can correct it by checking the albumin levels. We all know how to do that. Check for serum parathormone. Normally, it's up to 65 picograms per ml. If it's increased, you need to look for the reasons for that again. Check vitamin D3 in all patients and check for 24-hour urinary calcium. So these are the laboratory investigations for diagnosis of hyperparathyroidism and the various causes which can lead to it. In imaging, the simplest imaging is sonography. Like, you know, it's very simple, non-invasive kind of thing. You know, it can detect a lot of things. However, it cannot detect multiple glands sometimes. The best scan, best investigation, if you ask me, would be a technetium 99M system EB scan. Now we need to realize that this is an isotope which is, taken up by both thyroids and parathyroids. However, the thyroids, don't really take it in for a long period of time. It would really wash out of thyroid very soon. In abnormal parathyroid, it would continue to persist, right, because of the abnormal activity which is present. And that is what actually tells us if it's functioning. Now let's have a look at various scans. Now this is a normal technetium 99M system EB scan. Right, what we look as, this is the early 20-minute delayed phase. You see the thyroids which are happening. You also see the salivary gland having an uptake, and then it washes out of thyroid 1 hour. This is 1 hour delayed, and it's kind of washed out by the time you reach the 2-hour thing. So by 2 hours, it's usually out, right? You don't see anything in normal scans. Now it can be a subtraction scan if you see here, and when you look at this, you have actually subtracted the thyroid out of this. So if there is a small adenoma, something hidden, you may actually come to know a subtraction scan is therefore better than a plain technetium scan. Let's look at various scans. Now this is what an adenoma would look like, right? Now this is an adenoma. It's already washed out. That's a 2-hour delayed image, right? It's a 2 hours delayed image, washed out of thyroids, but the parathyroid adenoma, which we see here, it's actually still showing that uptake of technetium 99 scan. Go to 3 hours, it's still visible, right? It's very faintly visible, but at 2 hours, it's very well visible, and it delineates it as a parathyroid adenoma. Now, if you see the subtraction scan, you see this in the last figure, very well documented on a subtraction scan. Therefore, it's considered better in many cases. Look out for multiple adenomas, right? We just talked about it. You see here on the right side, both the superior and inferior glands are getting involved. So that's a multiple parathyroid adenoma. The inferior one looks more active, and therefore it is still having an uptake even at 3 hours kind of time. What we see in this scan is a parathyroid hyperplasia. You see all the 4 glands, right? All the 4 glands showing an uptake, right? This is what a parathyroid hyperplasia would look like. And you have to watch out for this kind of a thing, and then have to treat all the 4 glands. One investigation which is talked about in that is SPECT, it's single photon emissions computed tomography. It is simply given technetium 99M, and then you do a CT scan. Obviously, it gives out very good pictures, but it's a very costly thing and not really required in majority. In fact, we get sometimes normal CT and MRI in cases, especially in revisions. I like to get that. And I love the parasagittal cut which my radiologist provides with me. If you see this, it tells me very well about how deep is it lying in relation to the thyroid, what's the relation with various arteries. So that's how it really helps me out. And sometimes when it's really ectopic, it's again very important to get these scans done. A terminology which we use is a 4D CT scan. Now what does a 4D CT scan mean? It's basically the 4th dimension is time. So parathyroid adenomas, if given contrast, they would take it up fast, as we see here, and then washes out fast. So its thyroid gland is still visible, in which you see the first picture, it's a non-enhancing thing present here, takes up contrast, and then the contrast washes out, right? So it distinguishes it from blood vessels, from various lymph nodes. That is how a 4D CT, you take CT scans at repeated intervals of 15 to 30 minutes. So therefore, there's a lot of radiation involved. but it's considered it's kind of gold standard if you really want to look for a parathyroid adenoma. Rarely, revision cases, when you can't find parathyroid, PTH venous sampling will tell you where, which vein is actually carrying more parathormone, and therefore that is very localized the parathormone. Now, various scans, right, which imaging which can be done. We look at this, the sensitivity and specificity of system EB and ultrasound is moderate. Obviously, system EB SPECT and 4D-CT is very high, but they are very expensive. Safety profile is not there. So my experience, ultrasound and system EB, both together, we get almost 100% localization and diagnosis. It's very rarely that you need to go for anything else except for revision cases, right? So this is what protocol which I follow and which we follow in our institute is getting a USG neck with a good radiologist involved in a system EB scan. The most important investigation is parathormone levels. Now it's just not pre-operative, it's also intraoperative and post-operative which is involved. So, when you talk about this, we will talk about this in surgery again, but when you resect the parathormone with parathyroid gland, which is suspected to have an adenoma, then within 5 to 10 minutes, the level should fall below 50%. Now, there are various criteria. The most commonly followed is the Miami criteria. And the Miami criteria talks about fall in parathormone level by 50% as compared to the pre-operative, minimum 50% fall within 5 to 10 minutes of parathyroid adenoma resection. If it doesn't fall as much, you probably have either not removed the adenoma, you removed some lymph node or some thyroid nodule, or there is another adenoma which is existing, right? So this is something which would really make sense, especially in the initial part of our surgeries. Now, importantly, 2019 paper, right? Intraoperative adenoma, does it really make sense? And the conclusion was that our data showed that intraop did not seem to improve the outcome in patients which have good localized thing already existing. Now, in our place, majority of times, I do not get an intraop PTH. However, when we started off, I always used to get it done. Even now, when I'm dealing with a revision, I'm dealing with a young patient, I'm dealing with a suspected multiple adenomas, I would always get intraop PTH done. So if you want to be sure you're dealing with a VIP patient, you want to be safe from medical legal, yes, you should get it done just to be sure intraop that you are not leaving any active adenoma tissue behind. So that's a very important thing. Many papers now mention that it's not required. However, let's follow it as much as we can. One thing which becomes very obvious is why can't we get an FNAC done, right, to be sure if it's an adenoma. Now, various papers, we don't get it done. The reasons are simple. One, it is, the fibrosis, the reaction caused by FNAC leads to a lot of fibrosis, making surgery difficult. Also, this fibrosis which happens post-operatively, the biopsy which you send may be mimicking a carcinoma. That also becomes an issue. So it's, unless absolutely required, don't do it, right? Another thing you need to realize is it may increase the seeding along the track, right? So don't do it, especially not with a bite bone needle, right? Because that would actually make the life of the patient hell, because you have actually spread the adenoma to various sites. Coming to the treatment aspect of it, right? I mean, surgeons want that. Now, obviously, surgery is a very important role. For all symptomatic patients, you do surgery, but we do get asymptomatic patients who do not have any symptoms. I recently had a patient who was planning to donate her kidney, right, to a relative of hers, and incidentally detected to have some parathyroid adenoma on ultrasonography, and then we had increased parathormone levels and increased calcium levels, but there were no symptoms which she had. So there used to be criteria like these, right? Serum calcium more than this, age less than this, etc., etc. Recently, the most simple guidelines exist that all patients, even if having asymptomatic adenomas of parathyroid, whoever have a reasonable life expectancy and are having safe anesthesia, they're not risky from anesthesia point of view, you should operate on them. So no need of any other criteria. If there is an adenoma, symptomatic or asymptomatic, if the patient has a reasonable life expectancy and safe from anesthesia point of view, go ahead and operate. right? But before surgery, you need to treat the hypercalcemia. Otherwise, the patient has a very high chance of cardiac events intraoperatively. How do you treat? You go back to endocrinology friends. What they advise us normal saline infusions, so up to 2 to 4 liters a day is given. Loop diuretics in the form of furosemides, leading to more urinary washout of calcium. We do use bisphosphonates very commonly now. So if you have to do a surgery maybe after 24 to 48 hours, give zoledronic acid, and the calcium level falls down very fast. But you need to operate within 1 to 2 days of that. You don't want to delay it further. Rarely calcitonin, we don't use it. So the first three are very commonly used at our place, and I'm very happy to see calcium being controlled pre-operatively with these things. Surgery, the traditional surgery was, explore all the 4 glands, right? And then you remove whichever gland you think is abnormal. However, the things have changed now. Now we talk about more about focused parathyroidectomy. What that means is pre-operatively you localize it well with the investigation which we have. We localize it and then remove just that area, just expose that area where the adenoma is suspected, and you remove it, right? Instead of really looking for every gland, you don't need to do it. You have things like intra PTH assays, you have things like radio guided treating which is being done. So all these things actually help us out. But now the thing is to go for focused parathyroidectomy instead of exploring all the 4 glands, which used to be a norm maybe a decade back. Surgery, right? You need to look for where all it can be, because we know parathyroids are known to be very tricky. Sometimes in thyroid surgeries, we are unable to find parathyroid, but that is what we should always do. In parathyroid adenomas, these are the sites where the superior inferior parathyroids can be existing. We'll be talking about that. Let me try playing a video. I hope it really displays well. So we use an incision which, it's kind of a very small incision which we now use. I usually go by the midline approach, and we give, separate the strap muscles, and then you identify the thyroid lobe. Sometimes a parathyroid, when it's adenoma, it just pops out and you can just remove it without really, looking at a lot of things around. But it may be, especially, in my experience, the right inferior parathyroids are usually, the ones which can be deeper to the recurrent. So when you see out here, that's your recurrent laryngeal nerve, and the adenoma is actually deep to it, and you need to really separate it out very gently so that you don't damage the recurrent laryngeal nerves. So it's usually, in my experience, right inferior parathyroid adenomas which can be deep to inferior in recurrent laryngeal nerve. So you need to really dissect it out, and you'll need to look for a pedicle sometimes which may be present, and be careful that you don't really damage the capsule of the adenoma, because otherwise if the cells spread out, those seedlings would require a revision surgery after a few years, which probably nobody would be able to do a very good job at it. So this is a very well encapsulated thing. Usually you have to dissect it out, and you need to preserve the recurrent laryngeal nerve. You don't want a benign disease to lead to a recurrent laryngeal nerve issue, and just dissect it off. You find a pedicle, use a harmonic, use a cautery, maybe ligate it off, whatever you think convenient enough, and the whole tumor needs to be removed in one piece. There is no role of piecemeal excision here. You do not want this to be burst out, as I earlier mentioned, and preserve the recurrent laryngeal nerve, which you see out here. This is a scar which you get after a few years. It's almost invisible. So we have done of all sizes, right? Big, small, multiple adenomas, parathyroid hyperplasias. All these pictures now are very common, and we all are happy to see this. It's usually a medial kind of a tumor. You don't want it to be very big. You don't want to be very small either, and that's something which really works out. We had our series of parathyroid adenomas. In fact, giant parathyroid adenomas are something which are more than 3 centimeters in size as per the tradition which I described them. However, it really does make a difference. The presentation, the biochemical things, the surgery really does not change whether it's more than 3 or less than 3 centimeters. In fact, we had a very huge series on that, and we became working it. Now that's a very basic surgery, right? However, we need to realize that there are huge series in the world literature of revision surgeries requiring for parathyroid, and that's simply because it's sometimes not found preoperatively. You also have to make decisions regarding men 1, young age, parathyroid hyperplasias. So what if you're not able to find a parathyroid adenoma intraoperatively, right? It may be very small, it may be not be possible to localize. So if it's in the superior gland, right, we look for the tracheoesophageal groove, look in the retropharyngeal space. You can also go inferiorly, right? Go below the inferior pole of thyroid, you look just above the thyroid cartilage, right? These are the common sites where the superior parathyroid gland can be. The inferior parathyroid, you need to explore completely along the inferior pole of thyroid, right? Look for it absolutely around there. Go for much inferior to thyrothymic ligament, and sometimes even revision surgeries may require thymus to be removed, and explore the carotid sheath. The inferior parathyroid gland can be there too. If it's still not found, you can go for an intraop sonography. Right? That's something which is being done in advanced centers. You can go for PTH sampling from various IJVs to be sure as to which part is really having it. Worst come worst, do a hemithyroidectomy and remove the parathyroid, right? And I've done it in one of my patients in the very initial stage. It was a revision surgery. I was not able to find the adenoma. Did a hemithyroidectomy, and I was hoping that the things would turn out well, and it did. And that's what something you can do. And if still it doesn't work out, you need to then explore the chest in the second stage, right? Because that's where then it probably lies. And you need to really focus on radiology very well when you're dealing with it. Parathyroid glands, it's you also need to realize that when you look at infrared, they're hugely fluorescent. So worldwide, it's kind of things which are being used. You put a probe out there, and then the inflorescence which comes out of it can be seen. It's very highly inflorescent. That's something which happens. Now, this was a patient who presented to us. It's, I think, a 2 years old thing. Now, with just a facial swelling, you see on the left side of her face, the maxillary area shows a swelling. This was the scan which was there, right? And looked like probably a malignancy or some fibroosseous tumor. Took a biopsy and it came out to be actually a Brown's tumor. And we actually evaluated her calcium and parathermal levels, got these scans done. So what you see out here is, when you look at this, what you see here is the Brown's tumor in the face. You look out here, and this is where the parathyroid tissue is. It's right in the chest, right? You see this? That's the area of the chest where it's lying. It's in the mediastinum. And it was obvious that, when you look at this, this will be pretty much inferior to our exposure. We got a radiology in the form of CT scan done, and you see this just posterior to the sternum. This lies the whole tissue, approximately 3 centimeters in size, adjacent to the aorta and the heart. That's 2.5 centimeter in the width, right? So this is where it was lying. And we went to our CTVS friends, and that is where we operated on it, right? The sternum had to be split. We used various retractors, we were just helping it out because we explored the neck also in this particular patient. And this is how the adenoma came out. And this is the post-operative picture, right? So if you see this, this is the, the lung and the heart. This is the atrium part of it. That's the ventricle, and that's all pulsating. And you have the various great vessels out there running. So it was a huge surgery which required a lot of dissection in the chest. And we could actually, it was very exciting for us to see the various structures in the mediastinum, the heart and the lungs really popping out, and the surgery which was done. We did a neck exploration also because there was a doubt of parathyroid adenoma existing in the neck also. And we actually excised it, and we found one of the glands having an adenoma in the neck. And obviously the ectopic tissue had parathyroid adenoma. Now, if the patient has MEN syndrome, right, the important thing is MEN syndrome, the chances of multiple adenomas exist, and therefore it's kind of a total parathyroidectomy. You remove all the 4 glands, and then you may actually kind of, put one of those glands which looks normal, half of that actually, if you really want, the half of the gland can be put in any of the places which we'll just discuss. So men would require total parathyroidectomy of 3.5 glands. If there is a parathyroid hyperplasia, that's again a 3.5 gland removal. You leave hardly 30 milligrams tissue behind. How do you decide what or which gland to leave? The smallest gland would be cut into 2 parts, and then you put it, and then leave some kind of a tag to identify it, right? This is what we did in a few of our patients. The parathyroid gland, the smallest of this, was divided into 2 parts, and one of these was, if you can really look into it, I'm not sure how clearly visible is it. This is the parathyroid, the gland half cut and being inserted into the sternocleidomastoid. You can actually do it in forearm, but obviously in our the ENT regime, we have the neck wide open. We are happier deal with it. So we put it in the sternocleidomastoid, and if then required, if this develops an edema, this can be removed. You see again here, that's your parathyroid tissue. This is where it's lying in the sternocleidomastoid when you do an auto transplantation. So that is how the half of the gland is auto transplanted into the sternocleidomastoid in case of parathyroid hyperplasia. Now, minimally invasive video assisted parathyroidectomy is also being done, right? My speculations are simple enough that if you burst this adenoma, you need to be very careful. So, thyroid surgeries, we all know it's being done. Parathyroid, the only thing you need to be careful about it should not get burst, because that's something which is going to be very tricky and make the life very bad for this patient because of various seedlings which will happen. Complications, hungry bone syndrome, right? That's simply because the bones which were lacking calcium before the surgery, now as soon as the parathermal level becomes normal, these bones start sucking out calcium from the blood. So they want to they want to gain strength. They were hungry for calcium, but because of that the calcium drastically falls down, and therefore you need to supplement calcium in these patients. It is reported in 25 to 90% of patients who are having preoperative bony lesions, right? And if the skeleton is not involved, if the symptoms are renal and not actually bone pains, then it is very less chance that you would have a hungry bone syndrome. So you would not have hypocalcemia if the bones are not involved, right? So if the bones are involved preoperatively, whether it's bone pain, whether it's multiple pathological fractures, you need to look post-operatively very carefully about hypocalcemia leading to tetany and other features. If it's not, you may be happy about it. The second problem which you may face is the recurrent laryngeal nerve or superior laryngeal nerve injury, because it may lie. And as I mentioned, in my experience, it's usually the right inferior gland which lies deeper to the recurrent laryngeal. All other three glands, that's the right superior or the left side, any of the glands, they are usually much lateral to the recurrent. That's just which I found. It's not mentioned in literature. It's just my experience which I'm talking about. So if it is right inferior, I still I really have to be careful about the recurrent and right inferior. That's where it's much of an issue. What's in my experience? So that's kind of the last slide for me. It's 96 cases which done, 44 of them being female, such as 97 now, I suppose. Yeah. Age range 22 to 63. So it's kind of usually from the second or third decade onwards, we start seeing them. Most common presenting symptom has been renal stones and bony pains. Pathology, parathyroid adenoma, single adenoma was found in 87 patients. Right, we had 2 patients with MEN1 syndromes. We had double adenomas in 5 patients. We had parathyroid hyperplasia in 4 patients. The gland involved was most common was left inferior, followed by left superior, then right inferior, the most tricky one, the right inferior, and then the right superior, right? So left side was by far the commonest. In that also, much more common was inferior. And the complications, we had 36 patients who had hypocalcemia or some form of hungry bone syndrome in the postoperative period. Only one of the patients actually had a recurrent laryngeal palsy, which was also transient, right? It was not a permanent palsy, but that's something which is very worrisome, and you need to be careful about it, right? So that's what it is from my side. It's a very short kind of a class, but an important thing, because parathyroid is now really getting into the ENT gambit, and as the diagnosis is increasing, we need to be careful, because there are endocrine surgeons who are doing this. General surgeons are almost not doing it now. It's only the ENTs and the endocrine surgeons. And if you have a good team working, this is a very good surgery to do, because the patient comes to you with multiple problems, and this surgery, which usually goes very well, cures the patient of lot of issues. So, as this statement goes, while it may seem small, the ripple effects of small things is extraordinary, right? And that's what a parathyroid adenoma is. It's a very small thing, the effect on the whole body is actually extraordinary, right? And the teamwork, as I mentioned, is the most important thing. Not just the endocrinologist, it's nuclear medicine specialists, orthopedicians, nephrologists. Many a times our patients have renal failures, and the radiologists, which need to be there, right, in your team, so that you know whom to bank upon in case you land up with any kind of complications, right? So thank you all, and that's where I end. So if somebody wants to discuss or comment or ask anything, I would be more than happy to discuss.
Sir, there was one request. Can you
Yeah,
repeat the Sestambi scan again?
I'll do that. Yeah, and it's very important. I'm happy somebody asked it. Okay, so let's just go to system scan. Right. So, if you ask me, this is the best investigation which is there. You want a very good friend in your nuclear medicine department, because, that would teach you a lot about where this gland is actually involved and existing. So, it's an isotope which is taken up by a lot of things. We do technetium 99 scans even for heart, right? That's a different kind of an isotope, cardiac activity. So, we have those also. But here it's the system B part of the technetium 99M. It's taken up both by thyroids and parathyroids, right? Importantly, out of thyroid washes it out very fast. Right? Within 1 hour, it washes out, maximum 1.5 hours. Parathyroid abnormal, right? Adenomas, it would keep on persisting for up to 3 hours or more, and that's the advantage which we take for coming out of this, for diagnosing it. Now, this is a normal scan, right? You have the thyroid taken up. Sorry, let me just focus here. Normal thyroid, 20 minutes, 45 minutes, it's still there, no abnormality seen. 1 hour, it's diminishing. 2 hours, it's almost gone, and 3 hours, it's not existing. As I said, it's in the heart, it's in the salivary glands, right? So it's in lower down in the gut also somewhere. If you look at a subtraction scan, right? A subtraction scan is when you subtract the thyroid out of it. So they can do it on the softwares which they have. And if there is an adenoma hidden somewhere here, it would just stand out very well, and that's how it would look like. We'll show in one of the sections which we have. Now, this is a case of parathyroid adenoma. Let's start from the beginning, right? You see some black dot out here that may be an adenoma. Keep watching for it, and that's a 20 minutes delayed picture. You see this blackening, this uptake becoming very strong. Say 1 hour, thyroid is now up, there is no uptake. However, this uptake persists. 2 hours, it still persists. That's a clear-cut indication of a right inferior parathyroid adenoma if your clinical and biochemical picture supports that. Right? You do a subtraction scan, and this is what you get. So thyroid is totally disappeared, and the parathyroid adenoma stands out very well in this. This is a picture of multiple parathyroid adenomas, right? You see these two glands which are standing out on the right side, superior and inferior, even at 1.5, and by 3 hours, it's just one of these glands. So when you're operating, you need to consider that the second gland in the right superior may still be active, and that is where I would always get an intra PTH in multiple adenomas. Maybe in a single adenoma, now I don't get it done. And this is a scan which shows parathyroid hyperplasia, right? You look at this, you see four glands standing out. Look at 30 minutes, it's still four of these. 1 hour, it's still four of these. Right? You don't see a thyroid uptake very well out here. It just is parathyroids which are standing out, and that is where you need to look for a hyperplasia. And obviously, the treatment therefore would change in the form of a 3.5 gland removal, right? Just if you add CT scan to this becomes a SPECT, which may not be really required in majority of cases, right? I hope I was, clearer on that.
Sir, there was one more question. What kind of neck incision do you give for parathyroid hyperplasia for all the four gland parathyroid?
Parathyroid hyperplasia, all four glands is, I would always, kind of give a thyroid incision which you prefer. It's kind of a 2 finger breadth above the sternal notch, or midway between the sternal notch and the cricoid. That's somewhere we would give. So whatever incision you're using for your thyroid surgeries, just use that. That's where it is, because you need to go on both the sides of thyroid.
Next question by Dr. Basit. How accurately can we locate the parathyroid gland using indocyanine dye and infrared camera?
Yeah, so it's something which I don't have a personal experience in it. Ames does have it, so I they have done a study on it, I think, and but it is a very good tool to use. Let me not comment on it because I have not used it ever. However, maybe in a few years to come, it will become an important tool. It really stands out very well. I was in the American Academy conference 2 years ago, and there was quite a bit of work which was shared on this, and you have all these papers which are full of it, with photographs of parathyroid really standing out with the fluorescence which was coming out in infrared. So it would come out in sooner or later to our part of the world also.
Uh, Next question by Dr. Hakeem Mohammed. How will hemorrhage be secured without devascularizing the thyroid gland?
Thyroid devascularization. Okay, I think if we can really ask it again, for parathyroids, they usually don't bleed a lot, in the sense that there is a one single pedicle which would be usually well identified, and you just need to somehow secure that part either by cauterization or ligation or harmonic, and that's good enough. It really doesn't bleed other than that. So when I'm dealing with an adenoma, I'm not really worried about hemorrhage in majority of my patients. What I'm most worried about is if the patient has thyroid nodules on USG along with the parathyroid adenoma. That makes my life very troublesome, because that thyroid nodule is something I may confuse with an adenoma during surgery, and I may leave behind an adenoma and actually remove the thyroid nodule and feel happy about it. So in that case, I would actually, and that is the case, it would bleed also, because you won't get a good plane. So you just need to look for an adenoma would always have a very good plane around it. It would kind of, if you put a finger and it would dissect out with a finger, it would come out very easily. A thyroid nodule would actually not come out so easily. You would actually have to cut it or cauterize it to separate from the rest of the parts. So if you're having difficulty in removing that suspected adenoma, is probably not a parathyroid adenoma unless it's a revision case. So that is where I would not be really worried about hemorrhage in parathyroid adenomas, and just cauterizing that pedicle does not devascularize the thyroid, so I would not be really worried about that either. Hope I answered it right.
Excuse me, sir. I'm Dr. Durga Prasad from Hyderabad.
Yep.
Yeah, you were mentioning about FNAC,
Oh, wonderful.
sometimes mimicking malignancy.
Yeah, no.
But
So,
with
no,
FNAC, we are going to get the cells out of it. How
no,
does it
no.
mimic
Okay,
malignancy?
okay. What I'm trying to say out here is that papers mention that FNAC would not mimic malignancy. What happens is when you do an FNAC, you breach the capsule, you lead to a lot of inflammatory reaction in the parathyroid, lead to fibrosis, etc. Now, what happens is when you do a surgery after that and you remove the adenoma and send it to the pathologist, then it may be confusing for them and they may actually consider it a malignancy. It's not the FNAC which will tell you a malignancy, but the post-operative biopsy can get confusing for your pathologist, right? I hope I'm clear on that. So FNAC per se will not make it look like a malignancy. The post-operative adenoma, when you have removed because of the inflammatory reactions, the various fibrosis, sometimes the breach in capsule which you see, they may think it's a malignancy. So that's the only issue which came out with FNAC. The second problem was obviously the seedling which may happen with that. And the third issue is you don't really require it. That's something which is almost never required with the kind of investigations you have. So it's not, okay, thanks for asking that. It's not that an FNAC would confuse it with malignancy. It's a post-operative thing which may get confused with malignancy. Right?
In the left lower parathyroid,
Yeah.
it's going to be inevitably near recurrent laryngeal now.
Yeah, it's near. But
Now,
what I have found is it's not really medial to the recurrent laryngeal. I usually find it much superficial to the recurrent laryngeal, right? Right inferior I found
so
deeper to the recurrent laryngeal somehow or the other. So let me again clarify, it's not mentioned in literature. It may be near to the recurrent laryngeal on the left side because of the anatomy which we understand, but I have always found it superficial to the recurrent, and it really comes out much more simpler, much more simply than the right inferior. Right inferior, I found it deeper to the recurrent laryngeal pretty often.
Yeah. So would you like to trace the recurrent laryngeal nerve and then remove the parathyroid?
Yeah, so not always. If it's very superficial, I'll not be worried, right? But if it's going deeper, always better to look at it. So it's just like a thyroid, right? I would always be happier to see the recurrent laryngeal, especially if it's right side. Left side, it's if it comes out easily, if it's popping out, I would really not make a lot of efforts to identify it. If it's going deeper, that's where the parasagittal cuts help me out. And intraoperative again. If it's anyhow looking that it may be going a bit deeper, then always look for recurrent laryngeal, right? If it's very superficial, it's popping out, it's very small in size, I would not really, frankly, I would not look for a recurrent in that particular patient. If I'm in doubt, always better to look for recurrent rather than thinking that it will be preserved, right? Just like thyroid, always try to look for it unless it comes out right. So
how many malignancies did you come across?
none. Okay, none. I'm so
Okay.
there have been patients which in fact we are doing a study at our place, and there were a few patients in whom I thought the parathyroid adenomas was very adherent and sometimes even hard on consistency, and I specifically asked our pathologist to look for a malignancy, but I really couldn't find any malignancy in all these patients. None malignancies.
And when you were forced to remove all the 4 parathyroids,
Yeah.
how did you supplement post-operatively? There is no parathormone.
Yeah. So we have always done a 3.5 gland, never a 4, but even 3.5 is almost like non-functional at that particular point of time. So the patient always is on IV calcium for at least 3 to 5 days in such patients, and then a very hugely supplemented vitamin D and calcium and magnesium in all these patients. Right, that's where you need an endocrinologist very badly. We would usually transfer these patients to an endocrinology ward, and that is after a 3.5 gland excision, and I would be happier to let them manage it, because they require a huge calcium supplementation, and they would still keep on complaining of hypocalcemic symptoms for pretty longer time, right? So that's a nightmare for the endocrinologist. I don't want to keep them in our wards, so we usually would transfer them. And in fact, worldwide, parathyroid adenoma surgery is otherwise getting into a daycare surgery now. We still keep them for maybe a couple of days at least, because I'm worried about these hypocalcemic symptoms. And if it's a multiple glandular, like you mentioned, parathyroid hyperplasia requiring 3.5 glands, it's a nightmare. You really badly need endocrinologist friends to really help you out.
So if it is an overt multiple endocrine neoplasia syndrome that you are mentioning, MEN,
Yeah.
so how often were you forced to do removal of a pheochromocytoma or other tumors or pituitary tumors? How
So
many times they were associated,
yeah.
and did you remove them?
Yeah. So parathyroid, one patient we had who had earlier had a pituitary tumor, right, had already undergone surgery for it, and now presented to us with a parathyroid adenoma. I mean, almost maybe 2 to 3 years after that. So this was one patient, and second patient had a pheochromocytoma which developed much later, right? I think that was approximately 7 8 years ago. So it's never that I have found these tumors simultaneously in any of my patients, right? But we have had a history of pituitary adenoma and then later on a pheochromocytoma. So this is what we had.
Did you come across any monograms or anything in literature, like some genetic studies, which can suggest us that the patient is likely to go into another endocrinal tumor later?
So if you're suspecting a Main syndrome, that's where I would.
Yeah. Men, you were telling
Yeah.
once
Okay. So
we
what
removed,
do you mean to ask
you
that if
removed
you have?
pituitary, after a few years parathyroid, after
Yeah.
a few years pheochromocytoma.
Yeah.
So
Yeah.
a sequence of tumors, is
Hmm.
there anything in literature, any genetic study that suggests that you can prognosticate this type of incidence of tumors in future?
So if it is a Main syndrome, right, you will have to watch out for these. I am not sure if there is any particular gene mutation, and that's an interesting question. So if I understand you well, what you're trying to say is that you already know it's a Main syndrome. Then what are the chances if if there is some other marker which would tell that this patient would more likely to get any of those
Yeah,
pituitary issue
exactly,
right?
exactly.
Yeah,
Yeah.
it's a good question. Now, if what I know out of it is, Men syndrome, if I'm suspecting, you would actually be look out for these things. I am not sure if, there's a particular gene mutation or anything, any other marker which would indicate that there is a higher chance of a pituitary adenoma or, pheochromocytoma. Yeah, look into it. Yeah, that's an interesting question. Yeah, not that I really know of any such
You
marker
said
exists.
of a thyroid nodule coexisting with a parathyroid tumor or something like that.
Yeah.
And in that case, you think a hemithyroidectomy along with the removal of the parathyroid should be advantageous?
So I've done that once. And if it's a big nodule, it makes sense. It really doesn't harm you anyhow. If it's a small nodule, the issue is, identification from parathyroid adenoma. But if there are nodules which are existing, if I am able to remove the parathyroid adenoma, I would not really go about removing one of those nodules unnecessarily. Right? I would be happy to just leave it, let it be there. In majority of times, I mean, I have not come across any of them really developing a very high, very big size of an thyroid nodule later on, which requires a surgery. But if it's creating issues with my, if I'm not happy that it may still be having an adenoma leaving behind, I will rather be happy to remove it only in those patients, or if it's a big enough tumor, which I would big enough
Thank
tumor.
you. And congrats for an excellent presentation. Thank
Thank
you.
you. Loved interacting with you. So thank you.
Thank you.
Sir, we have one last question, sir.
Yeah.
What is the role of ultrasound in detecting parathyroid adenomas?
Oh, very important. So all patients, ultrasound and system EB scan. Now, why ultrasound? Again, the same thing which Dr. Durga Prasad was discussing, right? An ultrasound would tell me if there's a thyroid nodule existing, and I really want to see that. If there is an ultrasound which tells me that there is a thyroid nodule, that would make my surgery tricky, and I would really be, very cautious in operating that patient so that I don't really remove the wrong thing and think that it's an adenoma. So ultrasound can tell you which gland is involved. It can tell you if there are thyroid nodules existing. So all patients, I get an ultrasound and get a technetium system AB scan, 99mm, right? So these two, they almost always I'm able to localize where the adenoma is, right? So, yeah. In fact, the person who is studying this, doing the study on parathyroid adenomas, Dr. Anshu is actually one of the people attending this. So if she wants to really comment on anything new which she has found, I mean, if we have time,
Oh, we have
and
time, sir. We have time.
and if she's interested in adding something, then she may add up, right? Anshu Rawat is there, right? And she's the one doing, quite a good work on parathyroid adenomas. Can we unmute her? I'm not sure even if she's. I
Yeah,
think she.
I have sent the request.
Anyway, so do we have any other questions in the meantime?
There's one last question by Dr. Abba. Isn't the preservation more difficult in thyroid surgery than removal of adenomas?
Yeah, absolutely. So that goes without saying, so to identify a parathyroid in thyroid surgery is tricky, right? We all had our learning curves, and now we are first it was only the recurrent laryngeal nerve, then it came to parathyroid, and now it has come to the superior laryngeal nerve. But I would completely agree on that statement that that is more tricky. Importantly, uh, the implications, when the good part about this surgery is it's not as difficult a surgery. It's a diagnosis, it's a post-operative thing, which is more important. And we should not be really, having an ego that ekdam se samne, we have seen it right now and we would remove it and that's gone for sure. That is where you have those revisions coming in, right? But otherwise, it's a very good statement to make that it's trickier to save them in thyroid surgeries rather than remove them. I would agree on that, unless it's multiple glands,
Yes, sir. Think,
right?
yes.
Okay, so I think do we need to see? I think there is just one question, Dr. Ankita. Please show slide on where all to look for gland. You want to share that slide once?
Yes, sir.
Let me see if we can find it. If we can't find it, I hope there is no further question on that, because that's an interesting slide. But wasn't this? Yeah. So this is where you need to look for. Right? Superior gland, you have specific places. It's just basically, as per the development of and the development and descent of these glands that you would usually find. However, it can be, a bit haywire, and especially the inferior glands can really go deeper down into the mediastinum. And we have had two cases in which it was into the mediastinum. I showed one of them, right? And it can be really deeper down into the mediastinum, which can be an issue. However, we had to split the sternum in only one of them, and not really other issues. So, yeah, and these are the other places, right? If you have any further questions on that, I think I can stop sharing it again. And then, I hope that's good enough. So people have done thymectomy, right? And the patient which I showed, that patient also actually they removed the thymus, which I didn't mention at that time, right? Okay. Yeah.
I think that's all, sir, for the questions from the chat section. Thank you once again, sir, for being a part of.
Thank you, yeah. I mean, we really want to see you back,
Yeah,
right?
actually, we are, of course, this PG series is done. We are actually planning to do a extensive series on radiology pertaining to ENT, sir.
Nice,
Around
nice.
15 talks are being planned from speakers from around the world, and of course, predominantly radiologists and also ENT surgeons.
Okay,
I think that would be little essential areas where
absolutely.
PGs would be really interested to watch, and hopefully we'll be getting on them by September or October months. Thank you,
Perfect.
sir. With this, I would like to sign off for the day. Thank you. Good night, sir.
Okay. Good night.